there are three procedures done commonly in the United States today. The adjustable band, the gastric bypass, which is the gold standard procedure that's been around the United States now for about 20 plus years, and a newcomer which looks very promising called the gastric sleeve. I've done probably more gastric sleeves than anybody in Southern California, and I think that it's important for a patient to have the alternatives, the three alternatives to choose from. Not any one of them is going to be the best option for everybody. And I think that the decision on which works better for a patient, even though I think most patients have already made up their mind about what they want when I see them, is something that we should discuss between the two of us when we meet to do a history and a physical. The comparison of the procedures is such that in a kind of a nutshell, the band is the safest procedure, but it is less help in terms of producing weight loss than the sleeve and the bypass. The people who choose the band because they don't want their anatomy rearranged. They like the fact that it is a lesser procedure, and they feel like that with just a good boost, they could, just a good solid help, that they could lose the weight and keep it off. People who choose the sleeve or the bypass have had experience with diets and failures, and they're pretty well convinced that they need a lot of help. Typically, they also have diabetes or hypertension, or they're very, very seriously overweight, more than, say, most patients that I see. Sometimes they don't feel like they want a foreign body, and they're less concerned about the surgical part of it and more about, say, having a foreign body inside of themselves and the long-term consequences of that. The band as an operation is the safest operation by about a factor of 5 to 10. It doesn't produce as much help for weight loss as the sleeve and the bypass. The distinction between the bypass and the sleeve is such that let's say if you look at complications, and they all have potential complications, is that the short-term complications are greater with a sleeve and a bypass and really consist of bleeding or leak and infection. With the band, the short and the long-term complications are slippage, erosion, and the port turning over and having to be replaced. What we know in the long term is that the long-term complications with the band, again, are slippage or erosion or port problems. With the sleeve, it's ulcers. The little pouch can potentially produce ulcers. The loss of weight opens up a space between the roux limb and the bypass stomach such that intestine can get twisted through there and cause bowel obstruction. And so that's one of the long-term complications of the gastric bypass. The other important long-term complication of the gastric bypass is a serious iron deficiency. When you bypass the stomach, you somewhat interfere with absorption of calcium and B12 and iron. And in an occasional patient, the iron absorption will be so seriously impaired that they will need intravenous iron supplementation on a 6 or 12-month basis for the rest of their life. With the sleeve, we don't visualize any of those complications occurring in the long term. We don't see that it's an ulcer preventive operation, so that shouldn't happen. There's nothing changed, so that a bowel obstruction really shouldn't ever occur. Iron absorption is not affected because the route that the iron takes, still goes through the same part of the small intestine for absorption. There is no band to slide, and so therefore slippage can't occur, and moreover erosion of the band through can't occur either. So that's the beauty of the sleeve, is that we think that it should be virtually free of long-term complications. The downside to the sleeve is that we only have about a 3 to 4 year experience with it. We know it produces really good weight loss for 3 to 4 years. We don't know what weight loss is, 15, 20 years down the line with the sleeve as we do know with the band and the bypass, and we know that those two produce good weight loss. So all three operations work pretty much the same way. They produce a small pouch so that you feel full sooner when you eat. They restrict the opening out through that pouch so that you have to chew more carefully when you're eating. And then they change the neurochemical feedback from the gastrointestinal system so that appetite is damped. With the band, it fits around the top part of the stomach, and it is adjustable so that the opening out of the pouch just above it can be regulated, and it needs to be regulated so that it keeps you right in the zone where you're having to chew a little more carefully, feeling full sooner, and it's damping your appetite. And most patients go along for a period through the first year of 4 to 6 weeks, and then at some point in time they notice, hey, I'm getting hungrier, I can eat more, and that's a signal to come in and have the band tightened. And that's done by putting a needle through the skin and subcutaneous tissue on the upper part of the body wall, and injecting some fluid that goes down through the tubing from the port to the band itself, and inflates the inside of the band and makes it tighter. Or you can remove fluid and make it looser. The gastric sleeve simply turns the stomach from a big bag reservoir into a tube, from the swallow tube, the esophagus, to the duodenum. And that tube has a volume capacity about like the pouch capacity above the band of, say, 60 cc's, and it has an opening all through the tube about like the opening out through the band of, the size of your small finger. The gastric bypass creates a pouch out of the top part of the stomach. Again, the size of the pouch is about, volume-wise, 1 or 2 ounces, the same as the pouch above a band or the volume of the tube for the sleeve. And the opening out of the pouch, which is achieved by connecting the intestine to the pouch, is made small deliberately so as to restrict food and make it necessary to chew carefully.